Hi, everyone. Welcome to today's webinar, Evidence-Based Treatments for Child Trauma in Arkansas. My name is Chad Severs. I'm your webinar host today, and I'm also the project manager for Arkansas Building Effective Services for Trauma. And we've got a great panel of speakers today, and you're going to be learning a lot about the various treatments that we've been disseminating in Arkansas. So just a couple of housekeeping items before we start. We're going to have lots of time for you all to ask our presenters questions. So we really hope you do that. And so just be sure to use your question feature, which is on the right side of your screen. And we'll try to answer those during the questions part of the presentation. If you're interested in earning a CU, just be sure to stick around to the very end. We'll have a code that's given out, and I'll need that to make sure you stayed with us to the end. If you happen to be watching this at a later date, we only award CEUs for attending live webinars. So we are recording this webinar, and we'll upload this presentation to our website. Our website's listed there on the slide. And if you are interested in evidence-based trainings, and what's going on in Arkansas, be sure to check us out on Facebook. It's kind of where we post a lot of our, daily events and stuff that is happening in Arkansas. So be sure to like us on Facebook there. All right. So before we begin, I think we all want to get to know our audience a little bit better. So I'm going to launch a couple of polls here so we kind of get to know who's out there listening. Okay. So I just, if you would take, 10, 15 seconds, answer this question. We just want to get a sense of who's out there so we can kind of best meet your needs. All right. We got a lot of mental health therapists, number of administrators. We got a good group of other people. Okay, maybe like another 5, 10 seconds. All right, looks like most folks have responded. So I'm going to close this. And hopefully y'all can see those polling results. So we got a good mix of folks on our webinar today. So thank you for responding to that. All right. Okay, and I'm going to ask you all a second question. All right, so again, just take 20, 30 seconds to respond to this. So have you received training in any one of these evidence-based treatments? I realize we might have some folks who aren't a child therapist, and that's okay. We like it when folks are here just to learn too. So just let us know. All right, maybe like another 5 seconds. All right, thanks. Okay, folks can kind of see. So most people have had training of some sort in trauma-focused cognitive behavioral therapy, so we'll be talking about that. So good. All right, I'm gonna hide that. Okay, so just real quickly before I'm going to turn this presentation over to our speakers, but the 3 evidence-based treatments we've been disseminating in Arkansas since really 2010. The first is trauma-focused cognitive behavioral therapy, evidence-based for ages 3 to 18. We're also going to be talking about parent-child interaction therapy, or it's for kids between ages 2 to 7. And also child-parent psychotherapy, and this is for little ones, 0 to 5-year-olds. So these are kind of the 3 evidence-based treatments that we're going to be discussing today. And just to give you all kind of a sense of where folks are located or where people have been trained, hopefully you can see those images of the Arkansas map. We started TF-CBT in 2010 and have the most coverage for that area. PCIT and CPP, it's more regionally based, and so that's where we're hoping to really kind of expand on that over these next couple of years, and we hope that we have some folks out there that are interested in getting all three of these trainings, but particular for CPP and PCIT. So just to kind of give you an idea of that. And all right, I'm going to turn it over to our first presenter, Safna John, and let her introduce herself and CPP.
Hi, everyone. My name is Safna John. I am a psychologist at the UAMS Department of Psychology over at the Child Study Center. I'm also kind of in the process of becoming a state trainer for child-parent psychotherapy within our state. So I'm really excited to talk to you about this model. You can go to the next slide, Chad. Okay, so before kind of getting started with what child-parent psychotherapy does, it's helpful to know who we're treating. So we're really looking to treat kids who are 0 to 5 years of age. And really, when I say 0, I mean 0. So I think the youngest kiddo now we've had in our clinic is 5 months old, all the way kind of through that early childhood, infancy, toddler, and preschool range. Child-parent psychotherapy is designed for children who have experienced some sort of trauma and are having difficulties thereafter. Those could be behavioral, attachment, emotional, developmental, and really what we ask for is consistent caregiver involvement within the therapy, but that caregiver can really range. It could be a foster parent, a biological parent, and I think one of the things that maybe makes child-parent psychotherapy a little bit unique when compared to other treatments is that as long as a bio parent or any type of quote-unquote offending caregiver is relatively safe, CPP can start at any time. So this may be a treatment of choice that is really helpful for families who are court mandated. And it most commonly occurs during weekly therapy appointments. You can go to the next one, Chad. So there are 3 basic phases of child-parent psychotherapy. The first is the foundational phase. CPP relies heavily on the idea that we can't intervene on that which we don't understand. And so we do spend a time with parents getting to know the child's trauma history, their current symptoms, their development. We also get to know a parent's trauma history and their symptoms because we know that each person brings in what they have experienced into their current relationship. We also take a look at the relationship to see what are the strengths and also the areas of growth. We then move into core intervention where we really target those areas of growth, knowing that it's within the parent-child relationship that children of this age heal. And finally, we focus on termination. Really, the average course of treatment for CPP is 20 to 32 weeks, with some kiddos going longer or shorter, kind of depending on what their needs are. You can go to the next slide, Chad. So really, I remember I talked about that assessment and engagement is really a phase of treatment. So while we're gathering this information about parent and child trauma history, parent and child symptoms in the relationship, we're really trying to understand the family's culture and make sure that the things that we are doing and thinking about are in line with the core beliefs that this family system has. This can be especially interesting for young kiddos who have had a lot of different families. Because maybe the family cultures that they've been in have been very different from one another. And then really treatment planning occurs as a joint enterprise between a parent and a therapist. We fully acknowledge within CPP that it is the parent's rightful place to guide their child through the healing process. And while I may be there to serve as a translator or a conduit or someone who can really guide their development into where it needs to be, we also rely on the idea that parents have instincts and things within them that we can help them to think through for the betterment of their child. Treatment planning is really informed by things that we gather in assessment, and goals really change depending on what we see the needs of the dyad are. You can go to the next one, Chad. So kind of some central principles of intervention for CPP. CPP is a reflective and primarily non-directive therapy. This is a little unique also because most of the time when we think about evidence-based treatments, we think about treatments that are much more directive in nature. So this is one where, especially if you're coming from a non-directive stance, it could feel a little bit more kind of comfortable or on your page from something that you've been used to. What we think about in CPP is really capitalizing on moments in session that illustrate things that we would like to change. We call those ports of entry. And really what we think about is, when I intervene, what effect does that have on the parent, on the child, and on the relationship? Okay. And again, like I had said, it really is the parent's job to help their child through their experiences and through the trauma that has happened to them. And our job is really to facilitate parents confidently assuming that role of protecting and helping their child to heal. You can go to the next one, Chad. And termination is a whole phase of treatment, because what we know is that kids who have been through trauma have had a lot of difficult goodbyes in their life, and we want to make sure that the goodbye they have from treatment is a good one and is really kind of a healing one within the context of their trauma. You can go ahead, Chad. The exciting thing that we know is that CPP works. It's been tested in a variety of settings with a variety of populations, with a variety of types of trauma, and we have results suggesting not only it works now, but even 3 years afterwards, when we collect that information, it has still led to improvements. We know that it enhances the parent-child attachment. It can actually increase the way that children are able to think, and their development is able to be back on track, and they're actually able to regulate the stress hormones in their body better. We also know, though, that there's 2 people participating in services, a parent and a child, and we see parents really benefit from participation in CPP. Their post-traumatic and depressive symptoms reduce along with those reductions in their child's symptoms. You can go ahead, Chad. And so really the training process for CPP is a process that takes 18 months. It involves 7 days of in-person trainings over the first 12 months of your training, and then twice monthly consultation calls, and also opportunities for you to get with the providers in your agency to engage in supervision. As you can probably tell from this side, it's a lengthy training process, and really the reason for that is many times this is somebody's first time ever working with a baby in mental health, period, let alone a baby who has been through trauma. And we really want to make sure that we're supporting clinicians in learning not only a new model, but a new population that can be really difficult to treat. So I'm hopeful at least that got initial kind of understanding of what CPP sounds like and looks like. And I know we'll have plenty of time to kind of answer questions at the end of the presentation too.
Okay, thank you, Dr. John, for that very thorough and brief explanation of CPP.
Sure.
Okay. All right, our next evidence-based treatment we're going to introduce you to is PCIT. And I'm going to let Dr. Pemberton take over.
Okay. Parent-child interaction therapy, or PCIT. Chad, you can go on. Was originally developed specifically for disruptive behaviors, so kids who are aggressive, defiant, throwing temper tantrums. The name kind of indicates what happens is that it's a parent and a kid interacting, and that's how the treatment works, or how the treatment happens. PCIT is officially classified as an evidence-based treatment, and its strongest evidence is for reducing child behavior problems, which is what it was developed for in the first place. It also has very good evidence for strengthening parent-child attachment. There's more recent evidence about its effects on child trauma symptoms and reducing parental physical abuse. It's like CPP, it's developed for younger children, a slightly older age range than CPP, so ages 2 to roughly 7. Depending on your kid, there's a few reasons you might not do it with the 2-year-old, or you might not do it with the 7-year-old, but generally those kids will be fine. One thing about PCIT is that you have to have a parent and a kid together. PCIT does have sort of specific requirements for how much contact that parent has to have with that child. It can be any kind of long-term, hopefully stable caregiver. So someone who looks like they're going to be in this child's life for a while, having a caregiver role. is fine. So whether that's a bio parent, a foster parent, other kind of guardian like a grandparent or whatever, but they do have to have in-person contact with that child at least 3 days of the week. So for example, a parent who is in the process of reunification and has unsupervised visits, the session plus at least 2 other visits during the week, that counts. But if they're not to that point yet, you wouldn't want to start PCIT until they get to that point. The population that we're talking about is generally going to be kids with behavior problems. You can do PCIT skills with kids who don't have behavior problems, but the main focus, especially in the second phase, is on reducing disruptive and defiant behavior. And it gets actually it gets a little strange or even boring if you don't have behavior problems to focus on. But it does help. Just the basic skills do help parents, regardless of what exactly the kid is doing. So behavior problems and/or parent physical abuse. One thing we always make sure we qualify is that PCIT does help parents who have been referred for physical abuse develop more appropriate parenting skills. As you know, appropriate discipline as opposed to becoming physically abusive in discipline. We do not do PCIT with parent sexual abuse perpetrators because that's a different thing going on. We don't need the child victims to become more compliant. But a kid who has had sexual abuse is fine for PCIT. Many of those kids do have behavior problems, as long as you're talking about a non-perpetrating parent who's participating with the kid. Okay, Chad? So when you're doing PCIT, the first and most basic thing is that the parent and the kid come together to nearly all the sessions. There are 2 teaching sessions where you just have the parent, but other than that, every session involves the parent and the child. And the way it works is through real-time coaching. This, in the way that Sapna just described CPP, is that the parent and the kid are together. PCIT is very similar to that, although the therapist usually will be out of the room coaching the parent through a bug-in-the-ear device where the therapist can see the parent and the child, but they can't see the therapist. The parent can hear the therapist, but the child can't. So that the parent is the one who is being the therapist or being the behavior management expert for this child. And the therapist gets to coach the parent in real time with real skills, telling them exactly what they need to do if that's what they need, or just praising them for what they're doing that's good in some cases. PCIT happens in 2 phases. The first is called Child-Directed Interaction, or CDI for short, and that focuses on building up the positives between the parent and the kid, using positive attention from the parent for positive child behavior. We can call this a sort of relationship enhancement phase. It builds it increases the strength of the foundation of that relationship. At the same time, it goes on and it is already helping the child with some regulation abilities, and the parent also. Then you move on into the second phase, which is called, looks like there was a slight typo on the slide, but it's called Parent-Directed Interaction, or PDI. And that can be referred to as the discipline phase, because at that point you focus on what's left, what's this child still doing, and you use very specific, consistent discipline skills to address that. PCIT, usually it'll last something like, you can say 12 to 16 weeks. It will tend to go longer because of if parents no-show a session, or it takes longer, you have a holiday, things get canceled. But we don't usually specify a time. You can say 2 to 3 to 4 months. But PCIT really is mastery-based. You don't stop until you're done. You meet the parent and the kid both have to meet certain criteria before you can say PCIT is done. And so we call it mastery-based. Okay, Chad? The evidence for PCIT has been researched a lot. It's been around since about 1970, and there's been research on it sort of continuously throughout that time. Has very strong effects on child behavior problems. There's been follow-ups that have followed some kids up to 6 years later, and they find that the improvements they stay in place. You may have some creep back upward from some kids in their behaviors, but in general, the trajectory of those kids is pretty dramatically changed. Parenting satisfaction, parent-child relationship strength, those improvements also are pretty profound and generally pretty lasting. PCIT has also been adapted for multiple problems in several areas, and it's been used with some adaptations and sometimes without much adaptation in many different countries, different cultures within countries around the globe at this point. Okay. As I said at the beginning, more recently, there's good evidence for PCIT having specific effects on trauma symptoms. One of the big studies that helped with this was in 2004, and that was parents who were court ordered for treatment who had been court referred because of physical abuse, and the ones who received PCIT had significantly less. They were significantly less likely to be re-reported for abuse later, and I think it was about a 2-year follow-up. PCIT helps things with, helping the parent establish a bond with the child. So you've got a better parent-child bond, and it gives the parent appropriate, consistent discipline that they can rely on instead of getting to the point where they are physically abusing the child. And so it makes logical sense that it would help, but it also there's also now a good bit of research also showing that it helps. Okay, so to get trained in PCIT, it is a pretty intensive treatment, and the training process is also fairly intensive. The requirements from PCIT International is that you have 40 hours of face-to-face training. Now, 10 of those hours can be, there's an online training that doesn't substitute for face-to-face training. You still need some face-to-face training, but those 10 hours of computer or online training can help. Now, the face-to-face training can happen in several ways. There can be workshops. There can also be co-therapy, where you're basically watching someone else who's a trainer do PCIT, or a combination. That whole process takes about a year. The key thing, though, is getting the case experience, which means you have to qualify to become an official PCIT therapist. Besides getting the training, the face-to-face workshop or whatever, you have to complete 2 full cases. Also, there is consultation and consultation consultation or video supervision with a trainer. And review of certain skills. So certain sessions have to be reviewed by your trainer, by you sending them a video, or if your trainer is doing it with you, they will actually be watching you do it. Okay, and as the slide notes, our next scheduled training where we still have some slots is in this upcoming February.
All right, thank you, Dr. Pemberton.
Thanks, Chad.
Okay. All right, the last evidence-based treatment we're going to talk about today before we get into some questions is TF-CBT. And I'm going to turn it over to Dr. Siegel, and he can introduce himself and tell us about TF-CBT.
Yep, Chad, and you can go ahead and move forward the slide. Benjamin Siegel, also a psychologist in the Department of Psychiatry at UIMS and a national TF-CBT trainer. I am pleased to see so many people have experienced training in TF-CBT. So some of you may know me from the 2-day training, from consultation calls. So I will provide a brief overview of TF-CBT. Trauma-focused cognitive behavioral therapy. It's appropriate for a kid within the age range of 3 to 18 with a known trauma history. It can be a single type of trauma, multiple type, chronic trauma, complex trauma. With sort of trauma symptoms. So trauma history and trauma symptoms, meaning that trauma, PTSD symptoms, other trauma-related traumatic stress symptoms would be appropriate for kids in TF-CBT. Kids may have depression, anxiety, and possibly behavioral problems as well. If we choose TF-CBT, we've made the decision that trauma is the primary focus treatment, the primary focus of need. Treatment settings, we could do TF-CBT are very broad, clinic, school, residential, home, inpatient, basically any setting where you would have a kiddo for roughly 8 to 25 weekly sessions. You can do TF-CBT. Go ahead, move on to the next slide, Chad. So as I was saying before, TF-CBT is roughly 8 to 25 weekly sessions. Typically they're hour sessions. Sometimes they're hour-and-a-half sessions. It is a model that we have heavy caregiver involvement, or we highly stress caregiver involvement. So roughly 50% of the therapist's time is going to be spent with the kid, and 50% spent with the child, and sometimes it will be child and caregiver together. The outcomes, TF-CBT has been well studied across the country, internationally, for a variety of traumatic events, trauma symptoms. What we see across those studies are improved trauma symptoms, as well as depression, anxiety, shame, behavior problems in the kiddo. And we also see improved parental distress, improved parental PTSD support, and parental depression. So wonderful outcomes for TF-CBT. Next slide, Chad. What TF-CBT looks like, we use the practice acronym for the components. It's broken down into 3 phases. The first phase is the stabilization phase. That's the PRAC within the practice acronym. So we're providing education around trauma, improving parenting skills, relaxation, emotional regulation, and helping kids cope with strong emotions related to trauma and their trauma experience. The middle phase is trauma narration and processing, and that's where the child directly talks about their trauma history, their trauma experiences, and the impact on them. The third phase, and these phases are roughly equal amounts of time spent, is the consolidation integration phase. That's helping to improve the parent-child relationship and working on any safety concerns, helping kiddo sort of make the shift from past focused to more current and future focused in planning for future trauma reminders, difficult events, and so forth. On to the next slide, Chad, please. So the TF-CBT training process, there is an online training at the link on the slide. There are free CEs. Completion of that is the first phase, followed up by a live 2-day introductory training led by a national TF-CBT trainer. At the end of the 2-day training, or the close of that, it's the completion of a consultation call process. It's attending 9 out of 12 twice monthly consultation calls with a collection of your peers led by a trainer where you will present cases, 2 cases that you're currently seeing, and the trainer will walk you through your cases, give you support and guidance. And that is the TF-CBT training process. Next slide, Chad. So we have done a lot of TF-CBT training since 2010. We have had approximately or close to 600 people complete that full TF-CBT training process. So that's the online training, in-person, and consultation calls. There also is a national certification process that folks can do. It's a little over and above that training process, but we have 21 people across from Arkansas that are nationally certified. Our next training, we'll give you specific dates in a moment, but the 2-day training will be in April in Little Rock in 2018.
All right, thanks, Dr. Siegel. All right, so I realize that was very quick and lots of information, but just to kind of recap when our next training dates are for the various evidence-based treatments, they're displayed there on the screen. So we hope to kind of get the PCIT and CPP dates out soon, so we are working on that. But if you want more information or have questions about any one of these evidence-based treatments, you can email our training coordinator, Lisanne Herod, and our email is displayed there, and we can follow up with you after this webinar or future. So a couple of questions that we get a lot are just deciding on which evidence-based treatment is a good fit for you. And so I'm gonna kind of open this up for the panel, and if you have questions that kind of come up, feel free to write those in the question feature. But the first one is, the first question you need to kind of consider is, what's the age group of clients that you typically see? And Dr. John, do you want to take a moment to address that?
Sure, yeah. I think we did it briefly between treatments, but to kind of summarize it across is you want to think, am I someone who sees kind of a lot of kids across the lifespan, or am I someone who really focuses or gets some more client work with younger kids? And so what we know is that CPP can go 0 to 5, PCIT 2 to 7, and TF-CBT 3 to 17, okay? What I would encourage you, though, is to think about the fact that what we know about young children is that they are really underserved. So many clinics won't even see kids below the age of 3. And so I would have you think about what's the age group of clients you typically see, but also what age group of clients would you like more training on and would you like to see more of? Because what we find is when we implement and train CPP and PCIT within agencies, many times that opens up their ability to accept referrals for younger kiddos. And so that's one of the things I would be thinking about when deciding which EBT you should train in is what's the age group of clients you see and also that you would want to see.
Okay, thanks.
Yeah.
Another common question that we get is, just considering what's causing the most impairment for your clients. And Dr. Siegel, do you want to take a stab at that one?
Yeah, and I think the things to consider, there's a couple of them. I think the first is if your clients, you see trauma driving the train, meaning that they have a trauma history and current trauma symptomology that may be in classic sort of form like PTSD symptoms, like re-experiencing symptoms, nightmare, avoidance of places that are dangerous or where the violent or dangerous or traumatic events happen, reenactment behaviors, so forth and so on. If trauma is driving the train and you're seeing PTSD symptoms, or you're seeing those classic PTSD symptoms along with maybe behavior problems, anxiety, depression, but you're still seeing the root cause of those difficulties as trauma related. That maybe there is significant depression, but that depression started after the trauma and the impact of trauma. And now there's problems with self-worth or depressed mood or loss of pleasure in activities. If you're seeing a lot of trauma is driving the train, then I would lean more towards TF-CBT or CPP. On the other hand, if you're seeing young kids, within that 2 to 7 range, and you're seeing a lot of kids with significant disruptive behaviors to the point that they're getting suspended, concerns about getting kicked out of daycare, a lot of aggression, physical, verbal aggression with siblings, with caregivers, you may lean more towards PCIT. A lot of kids with significant behavior problems may have trauma symptoms as well too, but PCIT, when we're going to choose that treatment with kids with trauma histories, behavior problems need to be the first and foremost focus of treatment. So the difficult behaviors are so concerning, impairing, that they need to be addressed first before we could do more traditional trauma work.
Okay, thank you. And we're going to let each of our panelists answer the next question here, but another thing to consider is who are the caregivers you work with? And Dr. Pemberton, do you want to start off with that and maybe through a PCIT lens?
Yes. Excuse me. For PCIT, you should think about in your setting, do you tend to get people, parents who are possibly going to reunify at some point? Do you tend to get kids who have foster parents who are relatively temporary and they change placements a lot? Because those are families that are going to are less likely to be able to do PCIT. On the other hand, if you get a lot of people getting referred to you who have biological parents or some other kind of long-term parent where there's not those are great parents to do PCIT with. Think carefully about what types of quote offending caregivers you work with. Again, we don't do PCIT with sexual abuse perpetrators, but if you're getting a family who there is a history of physical abuse, but the goal is reunification and everything's been reported properly, then that can be an appropriate PCIT family. So again, with PCIT, what you want, if your population that you work with tends to involve a lot of fairly stable long-term caregivers, or at least relatively long-term, then that's a great group to do PCIT with. On the other hand, if you've got a lot of people who are kind of temporary, that's not going to be as good. The goal is, with PCIT, we think about we don't need to create a super strong attachment in a caregiver who's not going to be there later on, because then the child just has to lose that attachment. So we are not going to focus treatment resources on strengthening that attachment unless there's some good reason for it. So you can think about your cases that way. Okay?
Okay, thanks. Dr. John, you want to add anything in how that might be differently if you're kind of thinking about CPP?
Yeah, sure. So really CPP opens the door to a lot of different types of caregivers participating in treatment. So we could have biological intact families participating, all the way to kind of families where the case plan is reunification. So the court and system is moving towards giving this child back to this parent, but there's still some safety concerns and still some areas in which they want to improve. What the model really implores us to think about as clinicians is the fact that many of these children are going to be returning home to the care of their biological caregivers, whether we feel like they're safe enough or stable enough or not. And so what we know is one of the best ways to help with safety and improving child outcomes is to strengthen the relationship in which they are going to be currently and in the future functioning. And so CPP maybe takes a little bit of a different stance on the idea of including temporary caregivers within the model, based kind of in attachment theory that really promoting any sort of attachment relationship as long as someone is safe and stable and relatively going to be into the child's life for the near future, that we would really want to help to strengthen that relationship so that those really young kiddos can heal their mental health symptoms and improve their regulation.
Thanks. And Dr. Siegel, any thoughts about TF-CBT and the caregivers you work with in that model?
Yeah, so, again, caregivers involved in TF-CBT is broadly defined. And so, we're working with caregivers that are relatively stable and will be consistently involved in that kiddo's life for the duration of treatment. That could be, bio parents, foster parents, adoptive parents, direct staff at residential, child welfare workers, whoever it may be that serves that role. Typically, TF-CBT is done with non-offending caregivers, although it doesn't have to be. Treatment would look a little different, and there are times where we could do TF-CBT under certain circumstances with an offending caregiver, as long as they were relatively safe and stable and supportive, and a couple other things as well.
All right. And we're going to let each of our panelists kind of address this for the evidence-based treatment they're talking about. But the other thing, when you're sort of deciding the evidence-based treatment's a good fit for you or your agency, is you're thinking about your clinical setting. Where do you work and how supportive your agency, and considering, how much time each one of these takes for training and all that. So maybe we can have Dr. Pemberton kind of speak a little bit about the PCIT.
Yeah, PCIT works best in a clinic setting where you can have a dedicated office for PCIT, at least as close as possible to a dedicated office, because there are requirements like having an observation capacity. You need very, very few other things in the room, like you don't need floor lamps or computers or that sort of thing, because sometimes the kids get really rough and things can get destroyed if they're in there. So we try to have a room with basically nothing in it except what you bring, the toys you bring in for your session, and a table and some chairs. That's pretty key. Also, it needs to be a place where a parent and a kid can both come. So if you work primarily in a school, if that's your main setting, PCIT is less likely to be feasible in a school setting. You're less likely to have a room for it. So if you're in a clinic that can have a room dedicated, that's the best option. You should also think about the training time. Would your agency be able to have the resources? You need some way to be able to hear and see the parent when you're not in the room with them, and for them to hear you. And so usually there's some audiovisual equipment that has to be purchased. I will say that most, the agencies we've worked with, everyone has been able to do it so far, and has sometimes it's a little complicated getting the materials, but it's worked out financially. But also there's things to think about, like would you be able to take the time that's required for the training? PCIT training takes about 7 days total away from being in the office. If you're going to come to a workshop, it's usually we do a 5-day workshop and then a 2-day follow-up. So that's time away from being at work. So making sure that that would be okay. So those are things to think about if you're considering PCIT for your agency. Is things like space. PCIT does require some investment on the front end. Everyone we've worked with, it has paid off quite well in the long run. Being able to see these kids, it kind of increases your referrals and that sort of thing. But that's all stuff to consider.
All right, thanks. And Dr. John, any clinical setting considerations for CPP that you want to bring to the group?
Yeah, I would, echo what Joy said about, Dr. Pemberton said about the idea that, that you'd want to have an agency that's supportive of the training requirements and things that you would have to do. Within CPP, it's also 7 days of in-person training over the course of 12 months, with the entire process taking 18 months. And there are routine, kind of consistent consultation calls that occur within that time, as well as we really ask agencies to provide space for clinicians to engage in what we call reflective supervision. And that's the idea of having a space with different clinicians to really process through and help you think about your case in a different way. And so what we have found is CPP works best if you can train with multiple people in your agency. So if it's just one of you in your agency, it can be a little bit more challenging to implement this model. 0 to 5-year-old children with trauma is a high needs population, and working with trauma is a high need thing for a clinician to do. So we really encourage agencies to either come together with 3 or so or even more clinicians within their agency, or regionally, if you all have a couple different agencies, maybe a couple different private practice locations around a regional area, to kind of come together to try and make a CPP team.
Okay, and Dr. Siegel, any clinical considerations that someone is thinking about TF-CBT needs to think about?
Yeah, for TF-CBT, I think the setting, it really doesn't matter as long as you have consistent access to the kid and the family for the treatment duration. So as long as you have access from roughly 2 to 6 months in complete treatment, then the setting would be appropriate. The sort of the time involved for TF-CBT is a little less than some other treatments. It's attending the 2-day treatment, 2-day training, and 9 out of 12 consultation calls over 6 months. So it's a little less of a time investment. But those, I think, are the main things to consider for TF-CBT.
All right. And, lastly, one of the things that you might want to be thinking about is, have you been trained in evidence-based treatment before? And I'll just kind of throw this out to our panelists, and, why might that be a question to consider deciding which evidence-based treatment is good for you? So throwing it out to our panelists, anybody wants to answer that one or start with it?
I think sort of for TF-CBT, I think one of the main things is being direct in treatment and directly feeling comfortable bringing up trauma and talking about trauma in every session. And folks may want to consider that sort of in choosing TF-CBT, that is more of a time-limited model where we are working through components, but we are directly bringing up trauma in sort of all sessions.
Yeah, I think to kind of build off that, one of the things that I think about is that CPP is a very integrative model, and so it integrates principles from a variety of orientations and experiences. So The good news about that is you can usually find something in CPP that really feels familiar to you and that you gel with pretty easily, maybe regardless of the prior training you had. But the downside of that is there's probably going to be parts of CPP that you are not going to be comfortable with initially, or you're not going to have experience within, regardless of what your background or training has been. So I think of CPP as a way to, much like all these treatments, to really build up your toolkit, but perhaps build up your toolkit in an orientation or a type of treatment that is very different from what you have been used to doing.
And with PCIT, if you have already been trained in something that's behavioral or cognitive behavioral, PCIT is less of a jump. PCIT can feel like a big jump to people who are primarily trained in non-directive approaches, because PCIT is very directive. Now, PCIT does actually train the parent to be less directive of the child, but you as the therapist are very directive of the parent. So if you've already been trained in TF-CBT, where you're fairly directive, PCIT is less of a leap. If you've been more trained in something that's heavily non-directive, it can feel a bit uncomfortable at first, and so moving into something like CPP first might be less of a leap, and then maybe PCIT after that, once you become more familiar with the with some of those concepts.
Okay, thanks. All right, so the next slide, we just have a couple of additional resources or things for check you out. I mean, really one of our main goals with this webinar today was to hopefully get folks interested or just open the door a little bit for these evidence-based treatments. The first, I guess, link or resource at the top there, the California Evidence-Based Clearinghouse for Child Welfare, that's just a really great resource to kind of do your own research and kind of check it out for yourselves. So if you go to that web page, you can type in any one of these evidence-based treatments we talked about, and they have little fact sheets and links to research articles and a lot of other helpful resources. The 3 evidence-based treatments we talked about today, I've listed their, I would say, their primary homepage. So Child Parent Psychotherapy, their Facebook is really kind of their homepage for all things CPP. It's a great resource, and PCIT and TF-CBT have their own dedicated websites there. So be sure to check those out. And if you are interested in upcoming training opportunities, 2 links to look into would be our ARBEST Facebook page. That's where we frequently do announcements and when registration opens for a training. And also on our webpage, we also will post information about upcoming training opportunities within Arkansas. So just before we go to the questions, there's one more poll that I would like to throw out to the group. And hopefully you can all see it. But so of the evidence-based treatments we've discussed today, which one kind of piques your interest the most? So just take a 5-10 seconds to complete that. Okay. All right, another 3 seconds. 3, 2, 1. Okay, I'll close the poll. All right, so it looks like we've got a lot of interest in parent-child interaction therapy, which is great. So we can, please feel free to follow up with us after the webinar today. All right, so we got a little bit of time for some questions from the group. So if you'd like to type in a question, please do that. We already have a couple that came in, so I'm going to ask those right now. And Dr. Siegel, I'll probably let you take this first, and if others want to jump in. But a person asked, is there a variation of TF-CBT that can be used with adults?
It's a good question. And I apologize for what may be a little bit long-winded answer. So TF-CBT, and we get this question a lot. People love TF-CBT, and they may be seeing some transitional age adults or that 19 to 23, 24 age range, and they ask, well, my folks that I work with, yeah, they're functioning more like late adolescents. Can I do TF-CBT? And the research answer would be it's not evidence-based for this population. But at least, clinically, we've seen a lot of the components of TF-CBT can be helpful for these kiddos. And there is research being conducted now by TF-CBT to see the evidence base and develop an evidence base and see if it would be applicable for sort of that transitional age youth. But as far as, evidence-based treatment for adults, because TF-CBT isn't at this point, and you shouldn't really be using TF-CBT with those age kids. Cognitive processing therapy. There is an online training for cognitive processing therapy, very similar to online training for TF-CBT. It was developed Medical University, South Carolina. So that you can get an online training for that. The other sort of evidence-based model, one of the other evidence-based models, prolonged exposure. Edna Fola's model is a good model. I would say prolonged exposure and cognitive processing therapy, there's a lot of similarities between TF-CBT and those two. Sort of the third model that as well, and there's sort of still the similarities across the treatments. EMDR is an evidence-based treatment as well too, or eye movement desensitization and reprocessing.
Thanks. We've got another question came in, and Dr. Pembroke, I'm going to let you take this first, but maybe each presenter can kind of answer this through their evidence-based treatment. But the person asked, has PCIT been shown to be effective with children who are on the autism spectrum disorder, or can you do PCIT with kiddos who are on the autism spectrum disorder?
That's an excellent question. That's actually been looked at a good bit in PCIT research. Yeah, the short answer is yes. The longer answer is, if you're talking about kids who are less severely on the spectrum, because if they're more severely on the spectrum, then you need things like ABA. But if what you're talking about is a kid who's on the spectrum and also has behavior problems, then PCIT is usually very good for treating those behavior problems. Kids on the spectrum respond quite well to the CDI skills. Sometimes, usually they respond fine to the second phase also. Sometimes that's a little more tricky. But the first phase in particular is great for the kids with autism, and usually kids who are relatively mild on the spectrum respond to PCIT just like any other kid with disruptive behavior.
Okay, thanks. Dr. John or Siegel, do you guys want to comment on working with kiddos who have developmental delays and various evidence-based treatments you've talked about?
Sure. So,
go ahead,
yeah, okay. So, yeah, absolutely. So since CPP is designed for children from birth, even children with kind of profound developmental delays can benefit from a parent who kind of is able to understand what their needs are in a more realistic manner. And so we find that CPP can be helpful for children who are significantly developmentally delayed to really focus on those emotional, behavioral, and post-traumatic symptoms that you're seeing. Strict behavioral symptoms, though, we often find that a referral, like Dr. Pemberton said, to ABA if it's significant autism, or things like speech, occupational therapy, physical therapy services are needed to kind of meet those additional developmental concerns within that population.
And then for TF-CBT, absolutely. I think for TF-CBT, as long as we have a kiddo that sort of is at the developmental level of a 3-year-old, the concept skills within TF-CBT would be appropriate. Of course, it would look a little different than TF-CBT with a kiddo not on the autism spectrum. For those that are interested, we have a webinar recorded on the ARBEST page, our YouTube page, that briefly discusses TF-CBT with kids with developmental disabilities. So that would be a good place to start.
Thanks. We'll take another question here, then I'll advance it to the CE slide. But and this is one that I can answer, is how much do the trainings cost? And the answer to that is that they are free. So fortunately in Arkansas, we are supported by the state. So we offer each of these evidence-based treatments at no cost. You have to pay for travel and lodging if you need to do that, but actually attending the trainings and the consultation calls Even the online trainings are free if they're required for the evidence-based treatment. So we're really fortunate in Arkansas to have that be the case. So there's not too many other states that are like us. So yeah, so there's no cost to attend the trainings. Yeah, good question. All right, I'm going to advance to the next slide because I know we're kind of getting towards the top of the hour here. If folks need to get on with their day. So if you're interested in earning the CEU, the code is displayed there. Just send me an email. And it's helpful if you tell me your first and last name, just so I can look you up quicker in the attendee list. If you're watching with a group of folks, just tell me the person who was the one that signed in, so I can just verify that. But so anyways, we'll take questions if you still got them. And we'll hang out here for a little bit. So please make sure to write in some questions if you have them. I'm gonna kind of go have this slide up here for a bit. Those are coming in. Dr. Pemberton, John Siegel, any kind of concluding thoughts that you want to throw out there to the group as they're discerning about these evidence-based treatments?
I guess the only thing I would say is that all three of us probably share in common how much we appreciate evidence-based care and urge people to get training in evidence-based models, even more than one. I think all of us on this call are at least trained in a couple of these models, if not all three. And so while you may not want to do all the trainings at the same time, we really don't want you to do that. It would be helpful to kind of think about whether more than one of these models over time is something that could really enhance your clinical practice. But either way, encouraging you to kind of broaden yourself within evidence-based practice, I think it's a great clinical goal, and it'll really help the families that you serve.
I would add to that, I definitely agree, you don't have to get trained in all of these, and there's other evidence-based models also for various other things. But think about it long-term, as Dr. John was just saying, is that, maybe choose which one you want to start with, but remember that that's not necessarily your ending point. Just because you say if you choose CPP first, that doesn't mean you're never going to do TF-CBT or PCIT. Just get trained in one at a time, and think long term of first do one and then move to another. And you have to kind of switch hats sometimes to go when you switch from one client of one and one to another. But most people are fine with that. If that's not a thing that you like to do, then maybe just become an expert in one of them. One other thing we don't think we mentioned is that it is possible for people to become agency level trainers and at least PCIT. If you're very interested in at least PCIT, if you become a therapist, there's also a method for becoming a trainer within your own agency. So that you could then be the one keeping it going in your own agency with new therapists.
The only thing I would add is I'm excited you all have shown interest, and I would urge you and encourage you to take the next steps, follow up with the appropriate folks, attend trainings. We try to make them as supportive, as fun, and interactive as possible. So please consider following through, and glad you all have shown your interest.
All right. Well, thank you all to our panelists for giving us some good information and stuff to think about. I'm just going to back up the presentation in a little bit in case folks missed the next training dates. So they have on their calendars, they can look at those. But that's all we have today for our webinar. So just please feel free to ask us questions afterwards. I will send out a certificate either later today or early tomorrow if you submitted that CEU code. So thank you, everyone, and have a great rest of the day.
Yeah, thank you, everyone.